next session is about to start on precision nutrition.
It's a great pleasure to be here today and introduce the area of precision nutrition, or as we call it, precision health and cardiometabolic disease in the program. For the interest of time, I will skip my slides and then we just go directly to the speakers of this session. And what I just wanted to say is that we don't have a clear definition of precision nutrition. And many people are thinking about personalized nutrition and precision nutrition in different ways. When we are talking about precision nutrition, we think it's a broader concept than personalized nutrition, and that it also encompasses ways of improving our dietary assessments, for instance, because that's also causing a lot of problems in the interpretation of differences in response to the same type of diet when we don't even know what kind of diet we are feeding people. So we think this is a concept that should be included in the concept of precision nutrition. So dietary assessment through objective markers like dietary biomarkers is also included in this session. So, but please let me introduce the first speaker of the session, and that is Dr. Jordi Merino. He's a molecular epidemiologist with expertise in human nutrition, metabolism, and genomics. He has done his PhD in Spain, and then he was doing his postdoc at UMass in Boston before he moved to Denmark to the Novo Nordisk Foundation funded Center for Basic Metabolic Research at Copenhagen University. There he leads the Genomics and Precision Medicine Research Group at this university, and they focus on the understanding of molecular heterogeneity that characterizes diabetes. So please, Jordi, the floor is yours.
Thanks, Rikard. That was a very nice presentation, and thanks for the invitation to present here. It's a real pleasure to be with such great speakers and audience. So I've been given 15 minutes, and I will try to respect the time to allow other speakers to present. I will talk about precision nutrition in diabetes. And before we start, let me acknowledge my potential disclosures. And whether it is a diet, a drug, a lifestyle intervention, or a medical procedure, there is large variability in how people respond to interventions. And this variability is a real challenge on precision, on evidence-based medicine, because postulates that all the people should be treated in an average way. And the reality is that none of us are resembling the average, and each of us may respond very different to the same intervention. So precision nutrition or precision medicine tries to handle this challenge, tries to understand why and how and when people are more likely to respond differently to a given intervention. Precision nutrition in diabetes is particularly relevant because diabetes is the poster child of heterogeneity. So the disease is currently diagnosed based on glucose levels, but the glucose is the symptoms. People have high glucose by many different pathophysiological processes that rise the glucose. And when we approach diabetes, we just treat the symptom, or we just try to to reduce glucose without paying attention on the mechanisms that rise glucose. So a few years ago, several diabetologists in the field realized that there is a need to better understand diabetes, and there is a need to understand why glucose is elevated. And we and others postulated that a much more refined approach to diabetes, which includes orthogonal access of information, glycemic phenotyping, metabolomics, genetics, gut microbiome, lifestyle factors, social determinants of health, integration of all this knowledge is needed to better understand the heterogeneity that characterizes the disease and identify a subgroup of individuals that are more similar to each other and could benefit from a given intervention, whether it's a prevention strategy or a treatment or a medication. There are many factors that can be taken for this risk stratification, but genetics has been taking the lead. And this is mainly through three different reasons. The first one is that genetic variation is fixed. Germline genetic variation is fixed, so it doesn't change across the life course. You analyze it once, and this doesn't change, and you have information forever. The second thing is that with a single genetic experiment, you get a lot of information that is not only applicable to diabetes, but to many other diseases and many traits. And the third reason on why genetics has taken the lead is that because then you can play with this information. You can do either post-GWAS analysis to better understand these associations, which gene are relevant, which molecular processes, in which cell types, in which metabolic stages, or you can generate polygenic scores. And polygenic scores provide a quantitative measurement of inherited genetic risk and can be used to identify people more likely to develop the disease. Over the last decade, polygenic risk scores has attracted a lot of attention, but there are questions that these traditional polygenic scores cannot address, especially when it comes to a disease as heterogeneous as diabetes. So during my time in Boston, I've been interested in using genetic variation to understand the mechanism by which these genetic variants influence the risk of the disease and try to identify more groups of individuals who share similar characteristics and more likely to benefit from a given intervention. In a hallmark paper published in 2018 by my colleague Miriam Adler, she discovered 5 groups of genetic variants that increase diabetes through specific pathophysiological processes. And these are related to 2 subforms of impaired insulin secretion and 3 forms of impaired insulin sensitivity. So when you generate polygenic scores with this pathway-specific genetic variants, you can identify individuals at high risk of diabetes who are more likely to develop either kidney disease or develop cardiovascular disease. And this information can have an impact in the clinical management of individuals with diabetes. We asked the question whether these polygenic scores could be used to identify individuals more likely to benefit from a given diet for the prevention of type 2 diabetes. And for that, what we did is to use data from 3 cohorts from Harvard, the Nurses Health Study 1, 2, and the Health Professional Follow-up, 35,000 individuals without diabetes at baseline with genetics and diet data. And we followed them for more than 20 years. So what we did is to generate 5 pathway-specific polygenic scores. We generate a health eating index, a score based on cumulative measurements of diet. In the course, type 2 diabetes is ascertained based with questionnaires. We collected time-varying covariables during the follow-up. And what we were interested here is in testing for interactions between genetics and diet on the risk of developing type 2 diabetes. If there is evidence of interaction, it means that subgroups of individuals might differently benefit from this healthy diet. So what we saw was that the 2 exposures were associated with the risk of type 2 diabetes. Higher diet was associated with lower risk of type 2 diabetes. Higher genetic risk score was associated with higher risk of diabetes. But when the 2 exposures were combined, we see this risk gradient with increasing genetic risk and decreasing diet quality, but no evidence of interactions. No evidence of interactions in the additive or multiplicative scale. Meaning that the 2 exposures increase the risk of type 2 diabetes separately, and that there is no synergy between them, which suggests that regardless of genetic risk, a healthy diet is associated with lower risk of type 2 diabetes. We were very upset about these results, but not that much, because all my previous studies in this domain in testing how genes and diet are associated with the risk of type 2 diabetes and related complications are null. I did not manage to find evidence of significant interactions between genes and diet, even though this is what I'm presenting here. It's an individual data meta-analysis, including people from 15 cohorts, more than 120 individuals, 20,000 cases of diabetes, 10 years of follow-up. We conducted many sensitive analyses, no evidence of interactions between genetics and diet and the risk of type 2 diabetes. But even though the results are null, I think that they are quite relevant, because they give us 3 key messages. The first one is the need to identify those at high genetic risk for type 2 diabetes, because they might need additional strategies in addition to a healthy diet. Those with a higher predisposition to genetics might reduce the risk with diet a little bit, but maybe we need to ask them to perform more physical activity or do other strategies. The second point that these results suggest is that healthy diets could work for everyone, regardless of your genetic risk. And this has implications for precision nutrition, because any kind of personalization needs to take advantage of the knowledge that we have generated on the role of foundational diets. And the third relevant question here is that we are looking at only one layer of molecular information, which is genetics, and maybe integrative approaches that include more information are needed for understanding the interplay between molecular and environmental factors in the development of type 2 diabetes. So at this point, you might feel, okay, genetics doesn't help, you can forget about genetics. And what I'm going to show you now is that it's not only a thing with genetics. I've been involved in the Precision Diabetes Medicine Initiative for the last 3 years. I was co-chairing one group that it's called Diabetes Prevention. And in this working group, we were 15 people from different countries, and we were tasked with the task to investigate whether there are factors that modify the efficacy of type 2 diabetes prevention strategies. So we asked whether social, clinical, behavioral, and molecular factors can be used to identify those who are more likely to benefit from a given intervention. So this study took 3 years. We did a full PubMed search and other medical databases. We did the abstract screening, extracted data from eligible studies. And at the end, we end up with 80 studies. So the studies that are here are, for example, a super study of the PREDIMED cohort that look at whether age is a factor that interacts with the intervention, and people older or younger benefit more for the intervention for the Mediterranean diet in the risk of type 2 diabetes. Or here there are super studies of the diabetes prevention program that uses genetic factors to see whether individuals with a given SNP are more likely to benefit or not from a given intervention. So after all this project and reviewing all the evidence, what we found was that there was no single factor driving this differential response to type 2 diabetes prevention strategies. So no age, no sex, no BMI, no fasting glucose at baseline, no factors were consistently associated with better response to intervention for the prevention of type 2 diabetes. Even though if we had seen something, the quality of the evidence was graded low or very low. And this is because most of these studies, all of these studies are super studies of already existing clinical trials, which didn't respect the randomization, which did not adjust it for potential confounding factors, or were not powered to detect interactions, because these studies were not originally designed to test for interactions. So these findings from our working group inform an international consensus report on the gaps and opportunities for the clinical implementation of precision diabetes medicine. We were one working group out of 16 working groups that assess the evidence not only for type 2 diabetes, but also for type 1 diabetes, gestational diabetes, monogenic diabetes, and not only for prevention, but treatment, management, and other aspects. So the study included more than 200 scientists from 28 countries, and it was published a few months ago in Nature Medicine. And I recommend, if you are interested in this domain, to read this paper, because we provide the key highlights with opportunities for translation and also knowledge gaps. And what I want to emphasize today in the knowledge gaps is that we identified in this consensus report that there are no studies designed to test precision medicine or precision nutrition hypothesis, which is a barrier for the eventual implementation of precision nutrition or precision medicine in diabetes or metabolic diseases. So one of the papers that we did not include in our systematic review is a paper that is from the PREDICT group. I'm sure that most of you are familiar with that. And it's a nice illustration that when a study is fully designed for a research purpose, can provide insights that are likely to be relevant. So for those of you that you are not familiar, the PREDICT study was a study conducted in the UK in 1,000 individuals, and then there was a replication cohort of 100 participants in Boston Mass General Hospital that was involved in the design and implementation of the study. The study is an intense 14 days assessment in which people are instructed to consume different foods and different meals, and they are connected to many devices and many wearables to better understand the determinants of response to diet. And the first figure that we provide in this paper is this huge variation in glucose. So this is people eating the same meal at the same time in the hospital under very controlled situations, and all that you see is this huge variability in the glycemic response to this meal. The most important result from this paper to me is this figure, which shows that there are many factors that contribute to the variable response to diet. And this one might explain why we didn't find anything in our previous studies. If you look at just one element, then the element explains a little bit of the variability. And what it makes a difference is that when you start integrating information about genetics, meal context, glycemic markers, microbiome, age, sex, when you integrate all this information, you start seeing the variability in response to diet, which were not captured in the previous studies. And with all this information, what you can do is to generate a machine learning model that accurately predicts how people will respond to this specific meal or other specific foods or items. So this is a nice illustration of how well, thoroughly designed a study can lead insights into the variable response to diet. The key question is whether this makes a difference in clinical practice. And there has been a couple of very recent randomized clinical trials that investigated whether algorithm predicted diet is better than a conventional dietary advice for the for glycemic traits and cardiometabolic features. So what I'm showing here is data from the Weizmann Institute, 200 individuals with prediabetes randomized to Mediterranean diet or algorithm predicted diet. And the main outcome was that after 6 months of intervention, those randomized to the machine learning diet improved the time that is spent above 100 milligrams deciliter and the A1C before and after the intervention. And then on the left side, there's the new, very new trial from the Predict team in the UK. Again, personalized diet versus conventional dietary advice. This time, 350 individuals in the US. The results were published a few weeks ago, and what it shows is that the personalized dietary advice is slightly superior than the conventional advice in terms of improvement diet quality, triglycerides, body weight, and waist circumference. Those are very short clinical studies, 6 months, 18 weeks. There are issues with the design and the way to perform the intervention. People in the machine learning diet tend to get more advice or tend to get advice more often. So there are a lot of caveats on these studies, but it shows that maybe a personalized nutrition can be beneficial for cardiometabolic risk factors. I just want to finish with this slide. Whether those are precision nutrition studies, real precision nutrition studies or not, what I think is that there is room for improvement when it comes to dietary recommendations for the prevention of type 2 diabetes. And I believe that dynamic and flexible approaches are critical. This is recognized in guidelines, but we don't know exactly how to do that. So here what I argue is that an approach that is based on the pathophysiological processes that drive the disease, which is represented in these 3 colors, purple, yellow, and gray, can provide initial information on how people can respond to specific nutritional recommendations. And then I think what is critical is that this needs to assess through the life course. Because you now at this time point respond to diet in a certain way, it doesn't mean that you will respond similarly in the next year or 5 years or 20 years. So with new approaches, I think that it's critical that we continue to refine dietary advice. And with all of this, thank the talented people in my group that are helping with these studies, funding support, and thank you for listening.
Thank you very much, Jordi.